We're live.
We're live. Excellent. Hi. We're actually going to go ahead with the presentation and so on in a few minutes. We'll just allow a few minutes longer for anyone who's logging in at exactly 7 o'clock, so we don't leave them behind. But we'll start in a few minutes. And
but in the meantime, we'll
do
the chit chat.
Ray and I will be Richard and Judy.
Not sure who's going to be Judy.
Yeah. Except that we don't have any guests.
Oh, we've got somebody else just come in. Yeah, here we got some Joe. So hello, Joe. Right.
It's all very strange because I have to stare at a camera that's nowhere near a screen, so I can't actually see what's going out unless I look away, in which case I then broadcast the side of my head.
Yeah, and Jean can hear, and Joe. Oh, that's Graham Williamson, who's a colleague of mine from. Well, you met him. You know Graham. He was co-organising in the first place.
Yep. So there's just actually me on camera. Ray's diligently working in the background.
And Joe can hear everything. So.
Doing all the hard work, typing away, making sure it all works okay. Whereas I just get to sit here and chat. We'll give it another minute or so, and then we'll crack on, I think. Do you want to say anything about what you do, Ray?
Okay, if you want. Yeah, I'll while waiting, I'll tell you what, I'll put on the other camera a minute. Zoom. So, hello. Well, Sito and Graham know me, and Jason knows me. But hello, Miranda, Jean, and Joe. I'm Ray Jones, and with Sito and Miranda, who's there in the chat room, we've set this facility up. We use it for our students, and we use it for open webinars. You'll see when you came in and logged in, you'll see there's some various seminars coming up that you're welcome to join or recommend to any of your friends, colleagues, or patients, or anybody. So we use it both for these external events and also for internal events. One of the things that you'll find is that if by chance the picture does freeze or something, you'll see just above my head there, above Tony's head when it hits back on him, it says if you press F5 to restore it again. So if for some reason the video and the sound freezes, you can do that. If you want to have a private chat with somebody, there you can click on their name on the participant list, which is over there on that side of the screen. And as far as I can understand, you're all watching in the broadband version, which is that you're seeing and hearing this. Otherwise, you wouldn't be able to see what I'm pointing at. If for some reason you were doing this in an NHS environment and the bandwidth seemed to be too low, sometimes hospitals don't give you enough bandwidth, not as much as you do at home, you can get the lower bandwidth version that Sito developed just yesterday, which just allows you to see the slides and hear the sound. Graham's, as you see, we can have avatars if you're logged in for the regulars. So Graham, Sito, and myself have got pictures there on the chat over there. But as your guests, you all look like IRA suspects. So sorry about that. I think I'll turn myself off now and hand back to Tony.
Am I?
Yep, you're on.
Okay, so well, crack ahead. I'm Tony Todd, one of the new haematologists in the North Devon, Royal Devon and Exeter Haematology Network. We we haven't come up with a nice mnemonic for that yet, so it's a little bit of a mouthful. Jason Capel was going to be joining me today, but unfortunately unforeseen circumstances have meant that he can't get down here, but he's logged onto the webcast and is watching in cyberspace. What I'll do is go very briefly, and it'll just be a short presentation, running through how the new service, the new network service looks, how many consultants there are, roughly the size of the service and the area that we cover, just to give you a feel for who we are and what we can offer. And then I'll do some interesting referrals that Jason and I have picked up recently. I think we advertised my last 5 referrals, but in fact we'll just do 2 or 3 because we do get some quite interesting cases and there's a lot of meat to some of these. We are interested perhaps in doing this kind of thing as a more frequent educational session if there's some positive feedback from this. Where we could do webcasts looking at a selection of interesting referrals from the preceding month or couple of months, depending on how frequently we do this. So if that would be of educational interest, do let us know. But anyway, just for now, we'll talk about the network service. Then, as I say, we'll do a few referrals, and then a chance for some interaction, questions, answers, and so on at the end of that. So the PowerPoint slide itself probably lasts not longer than about 10 minutes, and then we'll have plenty of time to take a kind of free-for-all after that. And of course this will be archived, so anybody who's not watching this live, hello, and well done for finding it in the archive. So, we're based, probably as most of you know, at North Devon District Hospital in Barnstaple, and of course the Royal Devon and Exeter in Exeter. We do clinics there, but we also have some satellite clinics. South Molton, there's a clinic once a month, and we've done some clinics in Bideford. The Bideford clinics haven't happened recently because of service pressures, but we have a new consultant coming at the end of this month, and we'll look again, I think, at the feasibility of those clinics. That, roughly, is the area that we draw referrals from. Please don't take that as geographical gospel, but that's broadly speaking where we source our patients from, and where most of the GPs we interact with are. So we cover about 560,000 patients. We offer what's called a level 3 service, and that means that we offer, of course, all the outpatient services, but intensive chemotherapy for acute leukemias, all treated within our network, and we provide autologous, so same person stem cell transplant for somewhere between 10 and 20 patients a year. That's done at the Exeter site, where we have 13 beds, 10 of which are individual rooms with highly efficient, particularly screened air, and positive pressure, negative pressure. So we do roughly 11 clinics a week at the RDvesvesE site, and 5 clinics a week at North Devon, although that will increase soon to be 1 clinic a month, as I said, at Stratton. And in all, we see somewhere between 11 and 12,000 patients per year across the whole network. Now, the 7.5 consultants, currently the 6.5, but the extra body will be joining us in a couple of weeks. Over the 2 sites, we have 2 clinical nurse specialists, 1 specialist registrar, a couple of staff grades, 1 at each site, clinical assistant, 2 clinical assistants, a clinical fellow, and a couple of F2s. And those numbers should increase slightly. We're going to get an extra clinical nurse specialist at the North Devon site, hopefully. And those nurses will be looking, or at least one of them, to run some nurse-led clinics. We're going to start up, as I'll mention in a moment, long-term lymphoma clinic. We're hoping to get an additional specialist registrar to cover the network, and we have an additional F2 from time to time in the service. Now, actually, before I go on to this slide about our interests, I just say I've talked about the network service, and we do, I think, now see it very much as a network rather than a service that's based on a single site with some presence at the other site. Now there are more consultants, and we're hoping, as I say, for a bit more expansion. We're trying to view this very much as a single service which happens to occupy 2 sites. And we're trying to make it as seamless as possible for patient transfers between those sites, and for bringing protocols from one site to the other, so that, you know, wherever you enter the service, be it at the North Devon site or the Exeter site, you have the same consultants, the same approach, and access ultimately to the same facilities and the same level of care. Now, going back to this slide, those are the 7 full-time consultants, and the 2 triangles there, malignancy and coagulation, very broadly represent the proportion of different interests amongst those consultants. So as you can see there, as the interest in malignancy rises, the interest in coagulation wanes. I'm very much at the left-hand side of that spectrum. I have a particular interest in chronic lymphocytic leukemia, although I have some interest in coagulation. Jason has an interest in myeloproliferative disorders, but also some interest, a considerable interest in thrombophilia. Many of the other names, I think probably most of you will know. Claudius Ruden's strong interest in myeloma. Paul is Paul Kerr. He's the final member of our team who will be coming towards the end of this month. I put a question mark under transplant there because although Paul has a transplant background, he's not had a chance to meet with us all and hammer out his area of specialist expertise. So he might want to develop in other areas as well, although we're very much hoping that he'll take a particular interest in transplant. Jackie Rule, another new member of the team, came in last year. Her interest, young adult malignancy, hematological malignancy, and thrombophilia, much as with Jason. And Richard Lee, I'm sure almost all of you will know, who does pretty much everything and carries a large measure of the department's burden on his shoulders, but has an interest in transfusion, as well as doing a lot of haemophilia work. So we all see a bit of everything. We all see general haematology, but we would like over time to move towards a more specialised service, and certainly each of us would welcome referrals broadly along the lines of that little chart. And that is really, we do see the service developing to a more sub-specialised service where we can offer clinics geared towards particular diseases, so patients have access at both sites to consultants who have, you know, the time to focus on, keep up to date with the literature, trials, attend the meetings for more specialised segments of haematology, and to get some more trials available for patients in diseases like chronic lymphocytic leukemia. It's roughly a fifth to a quarter of our workload in terms of malignancy, and currently we have no trials running for that, so we're very keen to get some of those, and I'm trying to get a few set up over the next few months. Jason and Jackie are setting up a thrombophilia clinic, which I think will be a service of hopefully some interest, because that thrombophilia, as we'll see in the referral section, is something that commonly comes up. I've set up with a specialist nurse in North Devon a long-term lymphoma clinic for the long-term survivors we're now seeing with many of these lymphomas. You know, in the 1980s we didn't really have great regimens for treating them. In the 1990s much better treatments became available, and now we're seeing patients who are surviving 10 or 15 years and they have all sorts of issues: early onset osteoporosis, early onset cardiac disease, and so on, that need to be managed, and indeed needs to be done in close liaison with GPs. Setting up with one of our pharmacists, a pharmacist-led clinic at the Royal Devon and Exeter site, and we're also having Claudius is getting a specialist nurse trained to do a similar thing for, at the moment at least, essential thrombocythemia and some of the more stable myeloproliferative disorders. And we're also setting up, or are trying to set up, an audio-visual link, video conferencing link between the Exeter and Barnstable sites, so that all the staff up there and the staff at Exeter can attend the same educational meetings that we hold in-house, so that patients who want to discuss with their consultant an issue regarding, for example, prognosis, treatment and so on, can do that on a day that that consultant is not necessarily in Barnstable. So I go on a Monday, but if one of my patients can only be free, or their family can only be free to talk to me on a Tuesday, then we can do that through the video conferencing link. But the real key thing that we want to know is what do you guys want from us? And that's something very keen to discuss towards the end of this. I mean, we see this new service giving uniform level of care across the two sites, covering quite a large area, but while we have our idea of what we want to do with that service, I think it's extremely important that we take on board the needs and desires of the GPs, who are one of our biggest user groups. So we certainly would welcome feedback from you as to how you would like to see the service develop. So I think while you're digesting all of that, since we've got the PowerPoint going, we'll just run into the last few interesting referrals, and then we can have a big discussion towards the end. So just a few things. I had a very interesting case recently. A Middle Eastern lady, Egyptian lady, was referred up with hypochromic microcytic anemia and thrombocytopenia for further investigation. Now, there are only really 5 causes of hypochromic microcytic anemia: iron deficiency, heavy metal poisoning, the anemia of chronic disease, sideroblastic anemia, a form of myelodysplasia, and hemoglobinopathies like thalassemia. The thrombocytopenia, though, is the interesting element to that. Myelodysplasia could certainly cause that, and it can go occasionally with sideroblastic anemia. But a fact that is underappreciated, perhaps, is that iron deficiency can cause thrombocytopenia also. More typically, it's associated with a normal platelet count, or a platelet count that might even rise, because often iron deficiency is due to chronic hemorrhage, and that provokes a mild thrombocytopenia. But when the deficiency is severe enough, pancytopenia can occur. So not only a fall in the hemoglobin and a reduction in size and increase in pallor of the red cells, but a fall in the platelet count, a fall in the neutrophil count, although all the elements of the white cell count can fall. And indeed, this lady turned out to have a history of very poor diet. Unusual in the UK to see iron deficiency as a result of poor diet, but one does see it sometimes in members of certain cultural groups. And also menorrhagia, which of course is a little difficult to quantitate, although there are some tools out from the Royal Free offering a visual scoring system. And she did have a ferritin, which, as it turned out, was 12, which is quite low. She started iron, and her platelet count has begun to rise, and her hemoglobin has too. So that really just to highlight that iron deficiency doesn't only cause anemia. This is a diffuse increase in gamma globulin. It's a query that we get quite often. People have protein electrophoresis, as part of a more general check, and sometimes that will show up a paraprotein, of course, and then we get the referrals for possible myeloma, or there are various lymphomas which can also be associated with a paraprotein. But a diffuse increase in gamma globulin is also sometimes a somewhat unexpected finding that we're often asked about, and that almost never has a hematological cause in someone who doesn't have obvious lymphadenopathy or hepatosplenomegaly. The commonest causes for a diffuse increase in gamma globulin are connective tissue disorders, infections such as HIV, the chronic bronchitis can sometimes do it also, liver disease, particularly autoimmune hepatitis, cirrhosis, primary biliary cirrhosis, and a scattering of miscellaneous causes, sarcoidosis, of course, which appears on every list of differential diagnoses, but it's occasionally seen also in diabetes mellitus, and sometimes is idiopathic. It often goes hand in hand with an increase in the plasma viscosity. There was a study done by the Mayo Clinic some years ago. They took 100 or so patients with this, and about 6% of them had a solid tumour. Almost none of them went on to develop anything hematological, and the vast majority had connective tissue disorders or liver disease. So in a patient with an unexpected diffuse increase in gamma globulins, it is always worth looking at any of those conditions. And then finally, the more specific case, a 45-year-old lady, as you can see on the screen there, nearly 2 decades ago when she was pregnant in her 20s, she had a DVT. She had no family history of any problems. She had had no DVTs prior to that. She didn't have anything since then. She had, however, had a hysterectomy in her early 40s and was having postmenopausal symptoms, very reasonably, was being considered for HRT, and her gynecologist did a thrombophilia screen because of this previous history of DVT, and the results got sent to the general practitioner. And the thrombophilia results were normal/negative, so none of the genetic abnormalities that we screen for, like factor V Leiden or the prothrombin gene mutation, and normal levels of things like protein C, protein S, antithrombin. But the test was done, and the lady's GP was entirely understandably not entirely sure how to take clinical action on the basis of that. So sent a referral up to us. And I think that the key thing here is that she's had a DVT. And the Royal College of Obstetricians and Gynecologists recommend that HRT is avoided in patients with any history of venous thromboembolic disease. That's regardless really of whether they have a thrombophilic defect or not. Now, that makes the thrombophilia screen, to this patient at least, essentially irrelevant. Whether it shows an inherited defect or not, the RCOG guidelines would be that she should not receive HRT. The relevance of the screen might be, however, to her offspring. Not really to any male offspring, but at the age of 45, you know, she's if the pregnancy was successful, she's got a child, perhaps a daughter, who's now in her early 20s, who may be on the pill, may be going to get pregnant, and knowing that her mother has a thrombophilic defect might then make it worth testing the child, the daughter, because the presence of a thrombophilic defect may influence the decision to start the pill or the management of pregnancy, depending on the defect and depending on the history of the patient who has it. So, of no real relevance to the patient themselves, but possible relevance, the daughter had the screen been positive. The patient, therefore, was advised to avoid any hormonal therapy, to wear TEDs on long-haul flights, and so on. The long-haul flights is another common thing that comes up. Should we offer any patients anticoagulation on long-term flights? The answer is probably no, except for patients who've had a very recent operation within the last 6 weeks, say, or a very recent DVT. And even wearing TED stockings is a little controversial. If they are going to be worn, they should generally be well-fitting, and that generally rules out the TED stockings you can buy at Boots at the airport that most patients will go for. There's no proven role to taking aspirin on flights, although guidelines vary. The new guidelines out of the States, which are very influential, say no, but the Scottish Intercollegiate Network, the SIGN guidelines, say yes. But on the whole, other than walking up and down, not getting dehydrated and doing leg exercises, most patients don't need anything when they go on a long-haul flight. And kind of finally, just say that the thing with thrombophilia testing is the really important thing is the history of having had a VTE rather than any defect. If you've had a DVT, for example, then the most recent guidelines would recommend, even if that DVT is a first DVT, if it's unprovoked, the patient, if they're fit enough, should be considered for lifelong anticoagulation even after only one event, whereas more traditionally that's done after a second unprovoked event. Because warfarin won't reduce the risk of recurrence. There's about a 30% risk of recurrence if you've had a DVT or a PE that's unprovoked, And being on warfarin for 6 months or a year or 2 years simply delays when that recurrence occurs, but doesn't really reduce the risk of recurrence. And over a 10-year period, you're slightly better off being on warfarin and accepting the small bleeding risk than you are stopping the warfarin and accepting the 30% risk of a further VTE. And thrombophilia test limited. We can only test for a certain limited repertoire of known abnormalities, and there are almost certainly abnormalities out there that we don't know about that go untested for. And having a negative thrombophilia screen can give a false sense of security. And finally, it almost never makes a difference to what we do. In fact, the British Journal of Haematology recently published a review of thrombophilia testing and essentially said don't bother except in very limited circumstances, such as somebody with a strong family history who's about to embark on an at-risk venture like being pregnant or starting the pill. And the British Committee for Standards in Haematology advise that thrombophilia screens should certainly be interpreted by an appropriate specialist, which is almost always a haematologist. So the final slide here, the thrombophilia screen that Jason and Jackie, the thrombophilia clinic that Jason and Jackie are setting up, the aim is really to harmonise the advice and counselling that patients get, to reduce unnecessary investigations, and to have all requests vetted by a haematologist as a way of doing that. And they'll discuss requests that may be inappropriate with the requester and offer further advice. And of course, in the dedicated clinic, we can offer appropriate counselling to patients, not just testing, but we can talk about the risk to other members of the family, the risk if they get pregnant or go on the pill or start HRT, having had a VTE, regardless of any thrombophilic testing. And we hope that service will be very valuable and will be widely used, and we think GPs will be a major user of that service. That's pretty much the end of the presentation. And now Ray tells me that I'm slightly ahead of what you actually see. So we'll give it a few minutes, and then if you want to ask any questions, just type them in and send them in to us. And we've already got one question I'll tackle in a minute. But we'll just wait a few moments, see if we get any more questions, and then we can discuss those, or indeed comments or suggestions about the network service, or indeed what you might like to see in any future webcasts that we do. So we just have a break for a moment or two.
I think we could turn the sound off a minute, and in fact, Jason could always jump in with typed answers in the chat room, but then you might sort of sum up the whole thing. Maybe we'll.
Yeah. Okay.
We'll just turn this.
You'll.
Or we can leave the sound on if as long as we remember it's on.
Yeah.
We'll just leave it for a minute. Yeah.
Ah.
We've got in total 7 real people.
So, and three or four people who are just imaginary.
Well, Jason, Sito, myself, and Graham, who are here for the. Julian Cox, I believe, is from the deanery. I think, is that right? I think I recognise the name. Caroline Flynn, Simon Jones. It'd be good if.
Oh, Simon Jones, excellent. Hi, thank you, Simon, for sending around a lot of the publicity for this. A little unfortunate we've scheduled it for half term when obviously people are away, but it's a trial run just to see if this would work and if there would be any interest in it.
It'd be good if people actually made the sort of comment about the actual process as well, if they've got, even if they've not got any questions about the haematology or the clinic.
Yeah, no, feel free to make any comments that you like.
Harpashi, is that,
No.
Doctor?
Does that turn? Okay, so we got a couple of questions. I'll read. We got one about thrombophilia testing. I'll read that one out first because Jason is lurking in the background and may well have an opinion on this. So, how would you advise a woman who says her mother had a DVT but is no longer alive, so cannot be tested? Should she have a thrombophilia screen before starting the OCP? I mean, it would be useful, I guess, to have some more detail about the circumstances of her mother's DVT, if that information is available. Was it provoked, for example? How certain was the diagnosis? Did her mother have ultrasound, or was the diagnosis based purely clinically? Which, if her mother's no longer alive and died of old age, the diagnosis might have been made some years ago when perhaps testing was less robust. But I think Jason might want to speak to whether she should have a thrombophilia screen or not. My own feeling is it wouldn't be entirely unreasonable, but we'll wait for words of wisdom from the master. In the meantime, one of the other queries was, can you explain how plasma viscosity varies in PMR, which I assume to be polymyalgia rheumatica, because the ASR has long been used, and the PV in some cases more recent addition to the repertoire. I mean, I think as a general rule, the plasma viscosity and the ESR will co-vary and in the same direction, so that they'll both go up and down together, and they'll go up and down more or less in the same conditions. The slight difference is that the ESR is affected by things which affect red cells. So polycythemia, for example, will reduce the ESR. Anemia will cause the ESR to rise. Spherocytosis, which one can get in autoimmune hemolysis, sickle cell, and some other abnormalities of hemoglobin which cause red cell shape change will also lead to a decrease in the ESR. But I think in someone with polymyalgia rheumatica, they may well develop the anemia of chronic disease if they have poorly controlled disease, and that anemia may then cause the ESR to be falsely elevated, and the plasma viscosity is spared from any kind of interference in that score. So it's possibly a slightly better measure of inflammation. And the other thing is the plasma viscosity really is not as affected by age as the ESR is. There's only one study I'm aware of which compares the two tests directly in polymyalgia. And that was done almost 30 years ago in the late 70s, and it concluded that the ESR and the PV were essentially equal in monitoring the disease, were equally sensitive to changes in disease state. But it is occasionally possible to get patients whose ESR is up but the plasma viscosity is not, who have apparently active disease, and vice versa, though perhaps slightly less likely. So I think the PV, use it as you would have used the ESR, basically, I think, for pretty much everything.
There's another question from Miranda there. Do you want to
Oh,
do that? Or comment?
A comment, but yes, I think that's something that we could probably do better, and that is the weird and wonderful drugs like thalidomide, like lenalidomide, the son of thalidomide, and some of the less common things that we do, or indeed the less common combinations that we use. I think, sorry, it's been reminded to look at the camera there, it would be helpful for us to give more information out. And I think one thing we might explore with our nurses, especially when we get an additional nurse in post at the North Devon Hospital, is providing some kind of information summary for GPs. At the moment we give patients a printout of cancer backup information on each of the drugs that they receive, and that information is available on the website and it's very good, and we just print it straight off for patients because it's better than anything we might concoct ourselves. If it would be helpful, we're very happy to include a copy of that with the standard clinic letter. So when we start a patient on, bortezomib, Velcade, for example, we could include with the letter just a print off of the relevant side effects and other important things that need to know, drug interactions and so on. Also, and to get that up and running smoothly, there is a very excellent website from the British Columbia Cancer Agency in Canada. It's if you go to Google and you type in BC Bravo Charlie agency chemotherapy, I think you'll find it very near the top of the list. And they have a health professionals index of all chemotherapy drugs, which is absolutely superb. You get a PDF that details all the side effects, all the drug interactions, everything you could possibly want to know about these drugs, but it's quite readable. But I think, yes, it is incumbent on us, I think, to ensure that our colleagues in general practice are adequately informed about drugs that, by the very nature of our differences, you are not going to be so familiar with. And I think that's an area we will try and work on.
Jason's made a comment there if you want to read it.
Jason, depending on the circumstances of DVT, if in doubt, a thrombophilia screen may be appropriate. So I think we're broadly in agreement there. I don't know if there are no more questions coming through so far. So if Jason has anything to suggest or that we might want to comment for it, just alternate the word restriction on this.
It's Miranda saying that would be brilliant for us. We could get in the patient's records.
Yes, no, I appreciate you guys are 10-minute consult. It is hard to, as you say, Google all the stuff. I'll take that on board and bring that up at our next department meeting and see if we might be willing to adopt that as a departmental policy. And it's very easy for us. We just, on the clinic dictation, just say to the secretary, please include a printout of whatever. And in fact, when we're seeing the patients and consenting them, they get a copy of all of this, so it'd be very easy to print out another copy just to be sent off to you guys.
Jean Brown is saying it's an excellent way of communicating, but many GPs are still working at 7 o'clock. So when's a good time?
Yeah, when's a good time? Not entirely sure. I want to be doing this at midnight, but we can be flexible. I mean, potentially, well, maybe not a lunchtime slot because we're down here in Plymouth to use the equipment that Ray has very kindly allowed us to use. So it's probably not practical during the day. Although
unless you can get your own equipment.
Unless we can get our own equipment, which is something, if this was popular, it's certainly something that we would consider doing. We have got a small broom cupboard that we could use for this kind of thing. And if it was popular, then I think we would certainly look at getting some funding for that. But in the meantime, it's a trek down to Plymouth, and so the evenings would work best initially. But we can do it a little later in the evenings if that's a time that would suit people. The other thing that would be handy to know would be if there's a particular day that is more suitable than others for the majority of GPs.
Otherwise, we've sort of come to
I think
to an end for the minute.
I think we've come to the end of our inaugural webcast for the NDDH RDE Haematology Network. If anybody has any suggestions for a nice acronym or title for the network, they would also be very welcome.
We can make the recording available somewhere on the web wherever you want it. So
it's
probably on our archive if
yeah,
nowhere else.
It'll be on the archive here. It should be fairly easy to find. So by all means, tell your colleagues that you came and listened to the webcast and it was interesting, hopefully, and direct them to find it, because we'll keep a check of how many people actually come to look at the archived cast and get some measure of how much value there would be in doing another webcast. And I think a future webcast would potentially be largely a kind of question and answer session, looking at interesting referrals that we've done and then taking questions from you guys that everyone can listen into, unless there are particular things that people would like us to address in a future webcast, and we'd be very happy to look at that. Shall we...
Miranda just been asking whether the PMS had something along the same lines. As far as I know, the answer is no.
Not to my knowledge.
Yeah. But we could help them set something up if they want to.
Okay.
If not, I think we're finishing.
I think we'll call it. Thank you very much for taking the time to listen in and to interact with us, and hopefully we'll see you in a future webcast. Thanks again.
Bye. So, hello. Well, Sito and Graham know me, and Jason knows me. But hello, Miranda, Jean, and Joe. I'm Ray Jones, and with Sito and Miranda, who's there in the chat room, we've set this facility up. We use it for our students, and we use it for open webinars. You'll see when you came in and logged in, you'll see there's some various seminars coming up that you're welcome to join or recommend to any of your friends, colleagues, or patients, or anybody. So we use it both for these external events and also for internal events. Oh, that's Graham Williamson, who's a colleague of mine from. Well, you met him. You know Graham. He was co-organising in the first place.
Yep. So there's just actually me on camera. Ray's diligently working in the background.
And Joe can hear everything. So.
Doing all the hard work, typing away, making sure it all works okay. Whereas I just get to sit here and chat. We'll give it another minute or so, and then we'll crack on, I think. Do you want to say anything about what you do, Ray?
Okay, I can if you want. Yeah, I'll while waiting, I'll tell you what, I'll put on the other camera a minute. Oh, we've got somebody else just come in. Yeah, here we go. Got some Joe. So hello, Joe.
It's all very strange because I have to stare at a camera that's nowhere near a screen, so I can't actually see what's going out unless I look away, in which case I then broadcast the side of my head.
Yeah, and Jean can hear, and Joe. We're live.
We're live. Excellent. Hi. We're actually going to go ahead with the presentation and so on in a few minutes. We'll just allow a few minutes longer for anyone who's logging in at exactly 7 o'clock, so we don't leave them behind. But we'll start in a few minutes. And
but in the meantime, we'll do the chit chat.
Ray and I will be Richard and Judy.
Not sure who's going to be Judy.
Yeah. Except that we don't have any guests.
One of the things that you'll find is that if by chance the picture does freeze or something, you'll see just above my head there, above Tony's head when it hits back on him, it says if you press F5 to restore it again. So if for some reason the video and the sound freezes, you can do that. If you want to have a private chat with somebody, there you can click on their name on the participant list, which is over there on that side of the screen. And as far as I can understand, you're all watching in the broadband version, which is that you're seeing and hearing this. Otherwise, you wouldn't be able to see what I'm pointing at. If for some reason you were doing this in an NHS environment and the bandwidth seemed to be too low, sometimes hospitals don't give you enough bandwidth, not as much as you do at home, you can